So we've had a great set of data presented at the World Lung Congress here 2021, followed thereafter by the ESMO Congress in the setting of ALK-positive non-small cell lung cancer. I was privileged enough to present on behalf of my colleagues the final overall survival analysis of the ALTA-1L trial. You'll remember that this is a randomized open-label phase 3 trial of patients who have got first-line ALK-positive setting where they've been treated with upfront brigatinib or crizotinib. Prior chemotherapy was allowable in the frontline setting. The final overall survival data reconfirmed the progression-free survival advantage of brigatinib over crizotinib with, according to Burke-reviewed PFS, a PFS of 24 months versus 11.1 months, and according to investigators, 31 months versus 9.2 months, a clear PFS benefit which has been maintained. When we look at this more mature data, clearly maintaining intracranial control is really important for ALK-positive disease. And when we look at intracranial progression-free survival in patients with baseline CNS metastases, we see a really important PFS benefit for crizotinib, for brigatinib compared to crizotinib, with a hazard ratio of 0.29 favoring brigatinib. And this translates to a huge median intracranial progression-free survival benefit of 24 months compared to 5.5 months with crizotinib. The trial was designed with crossover built in, and 47% of patients crossed over from crizotinib to receive brigatinib. And also remember that brigatinib is one of the most potent next-generation ALK inhibitors with proven efficacy in the post-crizotinib setting, with a median post-crizotinib PFS of around 16 months or so. Taking that into account, when we look at the overall survival, we see that the hazard ratio for overall survival is 0.81, numerically favoring brigatinib, but has not reached statistical significance, in part driven, I think, predominantly by the significant crossover and the efficacy of brigatinib post-crizotinib, as would be expected. If you take account of the crossover by using a number of statistical modifications, such as the MSM method, we see that the putative hazard ratio would in fact be 0.54, that magnitude of survival advantage that we would be getting. One benchmark that we look at all the time is the 3-4 year survival rate in patients that are on the next generation inhibitor. And here we see that we have a 66% brigatinib 4-year survival rate, which is really what we're seeing with other TKIs, highlighting really that brigatinib's performance is not impaired over time at all. Indeed, when we look at the overall survival of patients with CNS involvement at time of diagnosis, we see that the hazard ratio is 0.43, so very important data. So let's look at other data that was presented at these two congresses. The other really important data set is a subset analysis of the CROWN data, which was presented at the World Lung meeting. Now, you'll remember that CROWN is a really important open-label randomized phase 3 trial of frontline lorlatinib versus crizotinib. And this updated data, forgive me, was presented at World Lung, having previously had the original efficacy data presented at ESMO 2020. You'll remember that that efficacy data set demonstrated a PFS hazard ratio of 0.28 by BICR review, which translated to a median PFS which is non-evaluable compared to 9.3 months. Now, one of the major concerns that folk have had with lorlatinib is the rate of neurocognitive or CNS adverse events that have been reported. And here at the World Lung meeting, we had further clarification on that. We learnt that the investigators had identified that 35% of patients had reported some element of CNS adverse events. And these were evenly split between mood-related events and cognitive-related events. And of these events, around 62% of patients required some sort of dose reduction or modification to help. Importantly, in the majority of patients, 76% of patients, that dose modification or treatment change did result in improvement of those neurocognitive effects. That then leads to the question is, does that dose modification have an impact on PFS? And really what the investigators have demonstrated is that when looking at the median dose intensity within the first 16 weeks, there didn't seem to be any impact on progression-free survival with that dose modification, which is really pleasing to see. So in summary, what does this mean? This means that patients do have neurocognitive effects with lorlatinib. They are quite frequent, and dose modification can frequently alter and resolve those neurocognitive effects. And so far, there doesn't seem to be an impact in terms of progression-free survival. However, I would say that these neurocognitive adverse events can sometimes be quite difficult to identify, and can sometimes be identified quite late and not early. And whilst it's pleasing to see that dose modification does resolve these adverse events, and that's been my personal experience with this drug as well, perhaps looking at the PFS early on isn't necessarily the best way of identifying its impact on PFS. And I'd very much like to wait to see more mature data showing the impact of dose modification on PFS. But certainly, this early data is very encouraging. Also, at these meetings, we've had updated data from our French colleagues who've retrospectively collected data on the BRIG-ALK study. So this is retrospective data on patients who've received brigatinib for ALK-positive metastatic non-small cell lung cancer that's relapsed after several lines of ALK inhibitor therapy. In this particular study, the median number of previous ALK inhibitors prior to brigatinib was 2, with an overall median number of lines of treatment 3. And when we look at the efficacy of brigatinib, it clearly has efficacy in this setting, but it is affected by the number of lines of previous ALK inhibitors. So with one ALK inhibitor, the median PFS is around 13.8 months, with 2 ALK inhibitors, 7.8 months, and with 3, 4.9 months, and proportionate reduction in overall survival, as you would expect as well. So what this tells us is brigatinib is effective in the relapse setting of patients with ALK-positive disease, and as you'd expect, with more lines of treatment, becomes slightly less efficacy, but clearly an active agent when required. There were data also that the group presented on patients that had used lorlatinib after brigatinib, and around 75% of those patients that had progressed on brigatinib did use lorlatinib, and the median PFS afforded by lorlatinib was 5.3 months. So demonstrating that we can sequence these patients really with modest but important PFS benefits on each occasion. The final data set is a data set that comes from China, which presented at the World Lung Data, looking at the ALK variants that we see if patients have EML4 ALK fusion. We know that if patients have EML4 ALK fusion, this is the commonest fusion that we see. There are a number of different variants that you can see. Commonest are the type 1 and the type 3 variants, or V1 and V3. Previously, we have presented from the ALTA-1L trial that variant V1 and V3 are the commonest. When we have analyzed outcomes by ctDNA, we've demonstrated that around half of the patients in ALTA-1L had presence of ctDNA, and the commonest variants were V1 and V3. In previous data sets, we've already knew that the V3 data set has a slightly inferior PFS naturally with any form of ALK inhibitor treatment, a prognostic effect of the V3 variant compared to the V1 variant. And in ALTA-1L, it didn't matter whether the V1 variant or V3 variant, the benefit with brigatinib was the same. compared to crizotinib. In this retrospective data set, a Chinese laboratory presented their data looking retrospectively at V1 and V3 and ensartinib use. The details of the ensartinib use are not that clear looking at the poster data, but certainly 50% of patients seem to have circulating ctDNA identified. And again, this is evenly split between the V1 and V3 variants. But according to the abstract, no obvious efficacy mitigation by ensartinib, which seems on the face of it to be very similar to what we've seen with brigatinib, although the poster does tend to suggest that the V3 variant seemed to have a potentially better PFS with ensartinib, although this is not very clear from the poster, and I really very much look forward to more details in the primary manuscript coming out in due course. So lots of data to be getting our teeth stuck into in the ALK setting, and as ever, we look forward to more and more granular data as data matures and we get more data coming through. So one of the greatest challenges I think we really have with ALK-positive non-small cell lung cancer is really working out the right sequence of ALK inhibitors to give for patients, and really working out whether they still remain to have ALK sensitivity or not. The uptake of rebiopsying for patients with relapsed ALK-positive lung cancer after ALK kinase inhibitor failure is not great globally, and that's partly driven because access to drugs after ALK inhibitor failure does not require genotyping. So we don't really know what ALK genotyping is bringing to the equation, rather than just switching to the next ALK inhibitor. And certainly the ALK master protocol in the US will help identify this. So I think the biggest challenge for ALK inhibitor usage is really working out the right sequence to use. What should we be using when? We always have to remember that the brain compartment needs to be thought about separately from the extracranial compartment, because we can have isolated CNS progression but not extracranially, and vice versa. And working out the right strategy for our patients with the drugs that are available is, to my mind, one of the biggest challenges. So the future for ALK treatment non-small cell lung cancer, I think, remains very rosy. There are a number of newer next generation ALK inhibitors in development, which with potential activity against gatekeeper and solvent front mutations. I very much look forward to seeing the data from these compounds as they come through in the course of the next year or so. We again live in very exciting times, and as ever, there's always cause for optimism in this setting.